And welcome to our final installment of the Society of Breast Imaging Summer Series on Facebook and YouTube. We're so excited that everyone is here tonight. I'm being joined by Dr. Jean Kunjman, who's my co-moderator, as well as some panelists who will be talking with us about really the patient experience and what to expect when coming to a breast imaging appointment and what questions are important to ask. So I'll let everyone introduce themselves and then we'll get started.
Go ahead, Meredith.
Oh, sure. So hi, everyone. It's great to see everybody back again at the end of our summer series. I'm Meredith Byers. I'm a breast imager in St. Louis, Missouri at Mallinckrodt Institute of Radiology in Washington University. And I'm going to try to stay on mute until we talk, because sometimes we got back.
Hi, I'm Jean Kunjman. I'm one of the breast imagers at Emory School of Medicine, and I'm also the director of breast imaging at the Midtown campus. I'm excited to be part of this final summer SBI series.
Go ahead, Ravi.
Hi, I'm Ravi Ramakrishna. I'm a private practice breast imager in Illinois. I apologize. We had a thunderstorm out here, lost power, so I'm in a place where there's emergency power. So if I cut out, I apologize.
Well, you're in luck. We got off to a little bit of a late start ourselves, so you're right on time.
Hey, everyone. Dr. Matt Miller. I'm a breast imaging radiologist at Allegheny Health Network in Pittsburgh, PA. I'm also the Associate Residency Program Director here. I want to say I'm happy that this summer series has gone as well as it has. I'm really ecstatic to be here on the last one with this great panel, and looking forward to another great discussion.
Great. So we're going to divide the discussion into three parts. We're going to first talk about before the breast imaging appointment, what to expect and how to prepare, followed by what are important questions to ask during a breast imaging appointment, and then questions that you may have after the appointment, or things that you may want to pay attention to or follow up on if you went after your appointment. So before the appointment, I just want to let the panel kind of discuss and go over what are some common things that you tell patients to do prior to coming in for a mammogram, and perhaps what are some things that patients may need to do but may not necessarily know prior to a breast imaging appointment.
I can kind of start. One thing that we kind of start with is to let patients know or ask them, is this your first mammogram or a baseline exam, or is this mammogram annual or follow-up mammogram? And just kind of getting some information, helping them understand what to expect at that first, depending on if you're a returning patient or is this your first exam?
That's really great advice. Dr. Byers, do you have other tips?
Yeah, can you hear me?
Yep.
So one thing we really stress to our patients is if this is not your first mammogram and perhaps your previous mammogram was done at another facility, we would love you to either bring your old films or at least have the contact information, even just the name of the previous location. One of the things that we do in breast imaging is that we hold on to mammograms for a long time. So if there's an opportunity for us to get your old mammograms from another facility, we're going to go to every link that we can to try to get that. So just having that information with you. Sometimes my patients say, oh, I have them at home. Can I bring them by later? Sure. Or I think I had them done at this facility, but I'm not sure. That's great. Give us that information and we'll do the legwork to figure it out. But your old mammograms are really a big help to us. So we try to make sure that we can have them if at all possible.
That's probably the most important thing, to be honest with you. As they say in radiology, the best view is the prior view. It's any patient that comes in that has had, where I'm at, we have a bunch of different breast centers, and there used to be more breast centers than they've consolidated, and medical records are all over the city of Pittsburgh, and I'm sure it's like that in most other cities. And during those times when people have kind of hopped between breast centers and whatnot, thinking, oh, okay, well, my records will just follow me. They don't. And unfortunately, we as a country, I wish we could get there to where you could basically have one medical record number and it follows you all over the country. That gets into another debate, but having your priors either sent, or you bring your priors, or give us the ability as breast imagers to find your priors, give us any type of lead, like Dr. Meredith said that if you think that I think in 2012 I had a mammogram at facility X. Well, that's more information than nothing, and so we can go and try to find that for you. But having just at least one prior mammogram, if you've had, you should be, we're supposed to say as breast imager, you should be getting your mammogram every year. And hopefully in the summer series, we've convinced you of that. But, things happen and, whatever. If you've had a prior mammogram 3 or 4 years ago, that's better than nothing. And that's not something that you should hide. That's, well, yeah, I haven't been doing great in getting my yearly mammogram, but I did have one, 3 or 4 years ago. We need that mammogram because it could save you a lot of headache and a lot of workup.
That's an excellent point. And I think that's really important to bring up, that there shouldn't be any shame. Absolutely. If there's been a few years since you've had your mammogram, we're just happy you're back and we're happy to see you. So even if it's from 5-10 years ago, bring it anyway. And,
try to avoid that, but don't be ashamed.
Yes. And as you said, the best view is the prior, and there's so many times that very, very small subtle cancers can be detected. And if we didn't have the prior, they may have not been as evident to us when we read the exam. So that's so important.
I agree with you guys too. All of you guys were saying the prior films are definitely the most important. If they have the prior films, I always tell your normal is probably somebody else's abnormal. So there's, it could look like breast tissue, but that might be the subtle difference that we could see from year to year. So definitely, in order to find small cancers and subtle cancers, the prior films are the key.
Absolutely. A couple of other practical tips, and I'll bring up the tip and then kind of let you guys discuss why it's important. One thing that we discussed prior to this session was reminding patients to not wear deodorant or antiperspirant prior to their appointment, and maybe one of you can touch on why that's so important.
I can talk. When you have the deodorant, it comes up as like tiny little bright white spots on mammogram, and which is like the tiny microcalcifications that we look for early form of breast cancer can also look like these tiny little spots. So in order to avoid we would make sure that all of them, that we don't get confused with the early form of breast cancer. It's definitely the deodorant and some of the skin lotions. If you can avoid that on the day of the mammogram, that would help us and help the patient as well.
Absolutely. Just to echo what you said, Jean, I mean, it's really, if you wearing deodorant or some of these lotions that contain different substrates or whatnot, it can confound our ability to read your mammogram, and we could potentially miss something under there. I mean, it's not only does it look weird because there's calcifications in your axilla bilaterally, but we could potentially miss something up there. And I get it. It's not an uncommon complaint for patients to come in and say, well, I've been out all day and I smell because you told me not to wear a mammogram, or you told me not to wear deodorant. Well, bring a deodorant stick with you and put it on after you get your mammogram, because you really want, in order for us to have the best diagnostic quality, you need to have no extraneous stuff on your skin.
Those are really great points. I'll just comment. We do provide patients with antiperspirant, deodorant after their exam to put on, and sometimes patients forget, and that's okay. We understand, in the heat of the summer here.
Absolutely.
Still, sometimes we can give you a washcloth. You can wipe that area, and your exam still can be performed. So if you accidentally forget, not a problem. We still encourage patients to come in, talk to their technologist, and see if it's okay to still do the exam.
And that really goes back to what Kimberly was saying about not having any shame. I mean, don't be ashamed that you forgot you wore your deodorant. Tell us. Don't lie and say, oh no, I didn't wear deodorant, and we get the mammogram and there's calcs all over the place up there. Tell us, it's fine. We can give you a washcloth or something and help wipe it off and try to, do what's best.
Yeah.
Absolutely. Those are all great points. Another commonly asked question that patients have is, does it matter at what time of the menstrual cycle that they come in for their mammogram? Does that impact their mammogram? And is it important to time out their mammogram, or really just come in at any time?
So I'll tackle that one. First off, that's in part a personal decision. I have some patients whose breasts are very tender around the time of their cycle, and just their personal preference is to time it after their cycle, perhaps on day 14 of their cycle, so they can avoid that tenderness. Now, that's not true for every patient, and that's really a personal decision. On the other hand, don't let your cycle impede you from getting a mammogram. If you know your period's going to happen the first week of the month and you want to time it later in the month, that's great. But still remember to get your mammogram. Don't let the concern about your cycle allow you to delay getting it at some point. I think we've all said this, but we have this sign up in our department. Mammography is a no shame zone. There is no shame. There is no problems. Come when you can. We will do everything we can to make it work for you. And the one thing, we talked about this a little bit on our last summer series, if you're worried about the compression, if you're worried about your breast tenderness, there are some things you can try. I think we'll talk about in a little bit, but remember, you as a patient in some ways control the degree of compression. So if you're worried about something squeezing too hard, being too uncomfortable, you're really in the driver's seat. You're the one really letting us know, okay, that's too much for you. We need to fix that. So your feedback is really important.
Absolutely. And related to that question and tenderness, this may be a good time to bring up also what to expect at the appointment as far as breast compression, whether it is in your control in any way, and if patients should expect discomfort, pain, and if so, for how long.
Yeah, well, just to kind of echo what Meredith said, it is, when you go to any doctor, not just mammography, not just your breast imaging appointment, and you're never forced to do something that you don't feel comfortable doing. I mean, when you say comfort, no one likes to get a mammogram. No one likes to get a rectal exam. No one likes to get, lots of different things that happen at doctor's appointments. So there's different degrees of comfort, but, so you have to understand that there's stuff that needs to be done in order to get an appropriate exam. But at the end of the day, if you feel like you're being hurt, or you feel like, that's enough, like Meredith said, that's, if you're, okay, this is all I can handle. No one's going to force you to do anything. This is, breast imaging. It's an important screening exam, but it's also an elective exam. So it's not to where they're going to put your breast into a mammogram machine and press down as tightly as possible. There have been the recent in vogue thing that's been kind of evaluated to varying degrees of success has been the patient-centered compression. I don't have any experience in it. I've read a few papers on it, and there's, like I said, varying degrees of success. Do any of you guys have experience with that, where the patient actually controls the amount of compression they have to get? So there's machines out there that the patient has to get to a certain level, and they're the ones that can control the compression themselves. No? I know that's kind of...
Never heard of it, but I love the idea.
I think we also have read on it, but haven't employed it personally. But the thing I hear most from my patients after their mammogram experience is that wasn't as bad as I thought it was going to be.
Sure.
So there is both an emotional and perhaps input and a level of fear about it, because if you haven't done it before or it's been a long time, you're not sure what it's going to be like. And getting through it, you realize that is very doable and I can actually tolerate that just fine. So don't let the fear stop you from coming. No fear, no shame.
Yeah, that's a great point, Meredith. You know, I guess the most unfortunate thing that we hear from a patient is that, well, that first exam I had was really painful, so I really did not want to come back for a few years. And if there is something that we could have caught earlier, that's really saddening to us. So I always tell patients, you know, just let us know up front. You know, your comfort, I think comfort during exams is something that's become much more of a discussion topic. You know, we want to get the proper information, but as Matt said, it shouldn't be a traumatic experience. Nothing really should be in this regard in the screening capacity. So it's important that we know that. And I think technologists are really keyed into that these days to really kind of work through with the patient, help them see what's comfortable for them. So that way they feel comfortable. And as Meredith said, yeah, patients say, you know, that really wasn't that bad when they have their first mammogram. And that's what we like to hear. I feel like a lot of times in Sunday cartoons and stuff, you see it as a joke, always mammography is, you know, they're showing something getting squished. And I think that's really in patients' minds. You know, it's funny, but when they actually come in for their exam, that's kind of in the back of their mind. And it's helpful to kind of dispel that kind of thought.
That's so important. Great answers. Another commonly asked question, or something that a lot of patients think about before their appointment that they may have questions about, is if they have breast implants and what to expect when getting a mammogram if you have breast implants. So if anyone would like to briefly discuss that and talk about how we make that as comfortable as possible for them as well.
Sure, I can talk. So when a patient has breast implants, we usually do 2 views on each breast. So one is just a regular mammogram image with the breast implant, and then they do what is called a displaced view, where the technologist pushes the implant back and just get the picture of the breast itself. So there's an implant included and implant displaced view. And I know one of the other questions that a lot of the women ask me is like, would the mammogram damage my implant? And the answer is no, because you know, the technologists know how to push the implant back and compress just the breast on the displaced view. That is where you actually put a lot of compression to see actually the breast tissue. On the implant included view, there's not that much compression. So the chances of damaging the breast implant is very little. I would say almost none.
Yeah, I've never actually seen ever an implant that's been damaged off of a mammogram. I don't know if that's, I'm sure, you know, it's never 100% in medicine, right? But yeah, I've never actually even seen that documented.
And I think to add to that, I said this last week too, we've all got good stories of ways implants have been ruptured. The answer has never been mammogram, although I have a lot of other funny things that have happened that have led to implant ruptures, but it's never been the mammogram. Yep. On the flip side, it's important for our patients to realize there's a reason why we're imaging both your breast tissue with your implant displaced and your breast tissue with your implant in place, because we're not only evaluating your breast tissue, which is very important, we're evaluating your implant as well. We can often give you information about your implant that without that exam you wouldn't have. And as implants have been becoming more and more popular over the last several decades, my practice sees a lot of patients with implants, and I think giving them information about their implant is as important as giving them information about their breast tissue itself. So we want to do your mammogram if you have an implant.
Yeah, I think that's a great point, Meredith. I mean, so you know, if you have breast implants, whether it's been for cosmetic purposes or if you've had prior surgery and you had breast implants for, you know, for those reasons, reconstructive purposes, getting a mammogram, you know, has more benefit to your overall health, not just from a cancer standpoint, but from, you know, to see the integrity of your implant. Now, it's not perfect. you know, just getting if you're concerned that your implant is ruptured, you know, a mammogram can rule it in, but it can't necessarily rule it out. So, you know, thinking that, you know, I'll just get a mammogram and I'll be done with it, as far as, you know, feeling like your implant is ruptured, you might need more evaluation, more than an implant, which could include an MRI, which is the gold standard for implant rupture. But yeah, I mean, that's just because you have breast implants doesn't mean you don't need mammograms anymore. In fact, I mean, there's even more compelling reasons to get the mammogram, not just for breast cancer detection, but, you know, to evaluate the implant integrity.
One thing that's also helpful for patients to inform us too is how long the implant has been in place. Some patients have had their implants for, let's say, 10 or more years. That fibrous capsule around that implant can calcify, become very firm, and that can contribute to pain during the exam, or it can create difficulty in displacing that implant. So letting the technologist know ahead of time is great information for them just to be aware of that. So as they position and start taking images, they know if that implant is going to move a little bit more, or if it's not going to budge because it's scarred down or it's been there for a long time.
Yeah, absolutely. Those are all great points. And another question that maybe Robbie wants to take this one as well is, patients may commonly ask or want to know when they come for the appointment, is my screening mammogram going to be read today? And why or why not?
Yeah, that's a really good question. And I think that depends on a variety of factors. You know, some facilities will give you results right away, so to speak. The radiologist will review that immediately. But many times the radiologist will review your exam, taking the time to review, get those prior exams, look everything over. And that can be the next day. Usually within 24 to 48 hours, you'll have those results, or your doctor will have those results, and you'll also receive a notification generally. Some facilities where you only have a screening equipment at the facility and the radiologist is not there, again, your images may be sent to another site to actually get read, and then can be included as part of that day's batch. So that can also add a day sometimes too. So not always do we read exams in real time, or you get your results immediately for a screening when you're not having issues. But generally within 24 to 48 hours, you know, your results will be available for you and your doctor.
One thing I would add is I think that's an excellent point about why we don't necessarily read them real time or read them immediately, is that at least in our practice, we practice batch reading. And we know that our sensitivity and specificity for being able to pick out, especially smaller subtle lesions, improves when we're reading mammograms in a group at a time. We know we get in sort of a rhythm, a routine, and our efficacy improves with that routine. So if you're a radiologist, if you had your mammogram in the morning, your radiologist may not be reading until that afternoon, because he or she is gathering up a certain number of studies to be able to batch read them, which really benefits you in the end.
Absolutely, that's a great point. And emphasizing and educating patients that it actually makes it easier for us to find cancers, and we may find more cancers when batch reading rather than reading the mammogram as in real time as it's obtained, which could be counterintuitive if they weren't given that information. Does anyone else have any tips, questions, or things for a patient to think about before or during their appointment, before we move on to after the appointment questions?
I'll just kind of chime in with the before the visit too. With caffeine intake, we get a lot of questions about, is it okay that I have my cup of coffee in the morning? And I think that kind of goes back to patient preference and how sensitive their breast tissues are during their examination. At least at our facility, we've kind of started to give patients the option that, you know what, if you have your cup of coffee and you don't have a lot of discomfort, you know, you probably are okay to continue having that cup of coffee or your soda or whatever. I think patients are a lot more angry when they don't have that coffee in the morning than the actual discomfort from their exam. And I think there's a trade-off, the risks and the benefits can sometimes be much more important for that individual patient. So again, I think it's just related to sensitivity and what you feel comfortable with. but that depends on how much caffeine you're drinking. If you're drinking a couple pots in a day, that's probably a different story than having your morning cup.
Absolutely.
I agree. The caffeine thing is patient personal preference. I mean, yeah, ideally, if you ask me, sure. I mean, if you can avoid it, sure, go ahead and avoid it. But I don't tell patients if they need their caffeine, by all means, drink your caffeine. Be happier.
Yes, and again, following our theme, don't let it stop you
Mhm.
from coming in for your mammogram.
Yep.
If you need to have your coffee and come in, just come in.
Sure. One other thing that I wanted to, if you're a patient who needs a translator, make sure you can, definitely come to the appointment and have the center get a translator. So you just don't want the language barrier to stop you from coming to get a mammogram. I'm sure different facilities have different translator systems, but all the facilities will have some form of translators, either by phone or by person. So definitely, if English is not your first language and if you need a translator, don't let that stop you from getting a mammogram.
And I know we're talking mostly about screening right now, but translation can mean a couple of different things. I mean, obviously there's the language barrier, but there's also, I always say that I'm the medical translator in my family because I was, I'm the first medical person in my family. So whenever there's anything medical, okay, Matt, what's that really mean? And so, I don't think I'd never tell patients, for diagnostic things, I have a very low threshold for allowing them to bring a family member back to kind of digest what I'm trying to say. I mean, obviously, biopsy and pathology results are one thing. And we absolutely encourage patients to bring their family members in for, whenever they meet with, say they have breast cancer and whatnot. And, that's that side of things. But even for diagnostic workups, okay, let me show you what an anechometry is. Let me show you what this mass that I'm seeing ultrasound is. And let me explain to you why or why not I think that I should biopsy this. And sometimes that can be overwhelming. Just that information in and of itself can be overwhelming. It's good to have someone there to kind of translate that, with taking them, it's hard to take emotions completely out of it, but, try, having another set of ears, having another brain there to comprehend things, that can help with just the knowledge translation. So I know we're talking about screening, and it's not very necessary to, take your husband or wife or, whatever significant other back to your screening appointment, really, because it's really just standing there and getting, your test done. But for more of those, explanation visits with diagnostic biopsies, like that, I have a very low threshold for talking to family members as well.
Absolutely. And a lot of times, even with, for example, a callback, which we'll speak about, and with biopsies, as soon as a patient has heard that something is abnormal, they might not hear anything after that. So it's important to have that family member there to kind of be taking in the information, even taking some notes about what we're discussing, so that later when the patient has finally had time to kind of process everything that's going on, they have more information, and their partner or family member or friend can help them to kind of remember what was discussed at the appointment and make sure they have all those important points that the radiologist has discussed with them.
Sure. Great points that you guys made. And, one other thing is, it usually, I know a lot of the facilities will let bring the family member or spouse, but due to the COVID, I would tell the patients to make sure you call the facility to see what their protocols are to bring in any of the family members or spouse during any kind of exam.
Absolutely.
Yeah, that's definitely a good question to ask now, as facilities may be doing either calling people in from the parking lot or having other procedures that are a little bit different to what we're used to. So we'll move into kind of what to expect after the appointment. what what questions a patient may have or what things they may want to discuss. So the first thing that I wanted to talk about is, what does it mean if I'm called back from my screening mammogram?
So that's a great question. And we can talk a little bit about how often people are called back, where we are evaluated, for example, as radiologists on our callback rate for the number of per 100 cases you read, the number that you call back. We have a target number of that. It could be anywhere from 5 to 6 up to 12 to 14, really depending on your practice and your style. But we also know that when women have their first mammogram, or what we call their baseline mammogram, they're more likely to be called back because it's our first time in seeing their breast tissue. And we're obligated to evaluate everything. We want to leave no stone unturned. And because we don't have a comparison, because it's the first time we're seeing that breast tissue, we want to make sure we're evaluating everything we can. So I have my technologists tell my patients, if it's their baseline, don't be surprised if you're called back. It means our radiologist is really paying attention to your breast tissue and wants to make sure that she or he has evaluated everything that they're seeing. But a callback, while I think in our patient's mind means one thing, and that's cancer, it actually, as you guys know, means a variety of things. It could be something that has changed over time, something that's new that wasn't there last year. Perhaps you have a cyst, a fibroadenoma, or another benign lesion, but for some reason at this point something looks different, something looks new, and we want to evaluate it. So for us, it's our opportunity to evaluate something that we see, but we know that is just by playing the law of percentages, typically it's not cancer. And we're going to go through a lot of benign or non-cancerous diagnoses to find the one that is cancer. But in calling you back, it gives us the opportunity to go through that process and make sure that there is or isn't something to worry about.
Sure. So I think that's a great point, that majority of the people that are called back do not need biopsies or have breast cancer. So as Dr. Byers was saying, that especially if it's a first mammogram, there are more chances that you get called back, but that does not mean that you have breast cancer.
Can I do something that's I don't think it's been done yet on this summer series, but I have this awesome picture that I like to show patients. I always keep it on my phone, and it's basically a diagram of the statistics of like callbacks and how many go to biopsy, how many of them get called back or whatnot. Based on, so I'm going to try and share my screen right here, and if it doesn't work, I apologize. But oh, never mind. I'm disabled from sharing screen, so I guess we're not sharing screen today. All right, never mind. So I wish I would have printed it up and showed you guys, but it's really a diagram. If you go to Mammography Saves Lives, if you just type in Mammography Saves Lives, there's a website that, and this diagram is on the web. It used to be pretty easy to get to. I haven't got to. I saved it on my computer, but it just reiterates what you guys are talking about. That the vast majority of people that have mammograms don't get called back. It's a little bit higher for people that are having their first one. But then of those people that get called back, the vast majority of them do not get biopsied. I watch the Hunger Games with my wife and my sister, and in that they always say the odds are forever in your favor. And so I use that sometimes for patients that they're talking, well, what are my odds? Well, the odds are in your favor. Every step of the way with breast imaging, the odds are in your favor. It's up to us as imagers to kind of manipulate or navigate those odds to make sure you're getting the best care.
Great point. And if we cannot get your screen shared, then I'm going to find the link real quick and I will comment on the Facebook Live so people can have access to that link.
It's a good point. It's good. Well, I can go to Facebook. You guys keep talking. I can go to Facebook and I can upload this image. How's that sound? Why don't I do that?
Perfect. So in the meantime, let's see, some other questions. So we've gone over a lot of the screening questions. So if other people have tips or questions about screening, we can discuss those. Or if you want to talk about patient expectations for a diagnostic mammogram or other imaging modalities or biopsy. We do have a little bit of time left. So if you guys want to go over any of those things, I think those would be super helpful for patients as well.
Well, I know I have to jump off pretty quickly, but there is something that's really important to me in my practice, probably important to you all. And I encourage my patients to make it important to them, which is to know your breast density. We are required by law in our state to notify every patient of their density and to include a statement that says, you know, with increasing breast density, there are both opportunities for additional screening and there may be additional risks for breast cancer. So we really want our patients to know what their density is and to understand. So much like Matt has the on his computer, what he shares about screening and recalls, I'm often sharing illustrations about breast density with my patients. And I like to make the comment that when your breasts are heterogeneously dense or extremely dense, I'm looking into a field of white and I'm looking for something abnormal that's white and it's hidden by something that's white. So that really brings home to the patient why we work so hard to examine every image, why we want patients to get annual mammograms so we can notice the slightest change, why if we call you back, we may use both mammography and ultrasound to solve the problem of what's going on, and why it's important for them to know their breast density. And so I feel like to me, I want patients to realize that's part of their health history, just like knowing what their blood pressure is, just like knowing their medications, knowing their breast density should be a piece of information that they have. In our center, you can ask the technologist to tell you what your breast density was at your last examination. You're welcome to ask about your breast density. We also have a nurse navigator who is available to consult with patients if they have specific questions about it. And not every place has those resources, I understand, but I still think it's important for patients to know that I consider that a part of your health history and health information that you should be aware of.
It's a great point, Meredith.
I'll just kind of add in the two that, especially when patients do get more information about their breast density, we always reinforce that mammography is still the foundation tool for those patients who have denser breasts, but you may need additional or supplemental screening, but never a replacement for mammography. So we still encourage patients who are in category the heterogeneously dense or extremely dense breasts to still come in for that mammogram. And then get more information about other types of testing that may be helpful to evaluate that denser tissue.
Absolutely. So since we do have a little bit more time left, the breast density issue is so important. And I think that, like Dr. Beyer says, that's a really good opportunity for a patient to be empowered with information about their breast health and be able to understand a little bit more the results of their mammogram. And when it comes to callbacks or coming in for a diagnostic workup, what are the types of things that a patient can expect during that appointment? How long does it take? What type of imaging are they going to do? And will they get the answer at that diagnostic appointment?
So the diagnostic mammograms are usually done for patients who have some kind of problems, whether it is some kind of clinical issues, whether it is a palpable lump, skin changes, nipple discharge. Those are the most common ones. Or if you got called back from the screening mammography, you get a diagnostic mammogram. So at most of the places, when you do the diagnostic mammogram, do additional pictures and of that particular area of concern. And if it was your time for your regular mammogram, we would do the regular mammogram of the both breast, but we would do additional pictures of the area of the concern. And depending upon what we see, we might need ultrasound at the same time to get the answer. So if it's a mass or palpable area or a lump, we always do the ultrasound to make sure that we know exactly what is causing the lump. And at our institution, and I would say most of the institution, we do the diagnostic mammogram, just like it's the same thing with a compression. but we just do additional pictures of that area of concern, and we do the ultrasound depending upon what the mammogram shows, and then we usually talk to the patients right then and there and give them the answer. As I said, from the diagnostic perspective, we usually have them come back in a year, or we tell them that there is something suspicious that needs to be biopsied, or very rarely, but if there is some things that which we think the chances of that cancer being less than 2%, we usually have them come for a short-term follow-up. So that's what we do for the diagnostic mammogram and ultrasound. So we do get, most of the places you should get the answer or the result of that exams right then and there.
I think it's important to, and that's a great summary, Jean. I mean, that basically goes down everything that a diagnostic workup is. It's important to realize, not only for patients that may be watching, but for also referring physicians who may be watching. I get the question, not infrequently, is there do you just look at the breast better with a diagnostic side? What is the real difference between a diagnostic CCMLO versus a screening CCMLO? And there's really no difference. So, every once in a while you get referring physicians who will say, well, I really think that with your family history, your breasts are super important. I want the radiologist to look extra hard at your breasts. So I'm going to order a diagnostic workup. And that's not really how a diagnostic workup should be done. As Jean said, really the two patient populations that are in the diagnostic pool are those with symptoms, palpable lump, pain, skin changes, etc., discharge, and those patients who were brought back from screening, who are the quote unquote callbacks that we talked about. So those are really the two patient populations that are in the diagnostic pool. You qualify for a diagnostic mammogram if you've been diagnosed with cancer in your lifetime. So occasionally, patients that have had lumpectomies will come, their annual mammogram will be a diagnostic mammogram. Do we really read that any different than a screening mammogram? Absolutely not. It's still a screening. If you haven't been called back and you're not having any symptoms, your mammogram is read like a screening mammogram. And we use the same X-ray beam to obtain a CC if it were on a screening mammogram versus a CC view if it were on a diagnostic mammogram. So I think that's one important thing that I always like to, especially when I have off-service residents and medical students rotate through, that just because something's a diagnostic mammogram, it basically gives us the freedom to manipulate the study to how we want. For calcs, we do mags. For asymmetries, we do spots, and et cetera. But the quality of the study is the same as if it were on a screening mammogram.
That's a really great point, man. And we tell patients too that that's also an opportunity for us to take some specialized views to look at certain areas, like calcifications. If we need to focus our attention on that, we'll do a specialized view. One thing I also want to add is that your diagnostic appointment is also a great opportunity to talk to your radiologist or breast imager. And as Matt said, that translation, ask them, what are you seeing? What does that mean for me? And that's a great opportunity when you come in for that diagnostic too. So seek out your breast radiologist at that time if you can, to get a little bit more information and have them go over things with you.
Absolutely. That's a great point. And we have a few more questions that the group had thought of prior to our session that may be relevant for patients. And one of those questions was, if the patient is about to move to a new city, state, anywhere, country, what should they do about their screening mammograms, and what are some steps they should take prior to moving?
So we talked about at the very beginning, people who jump around from place to place for no fault of their own. I mean, people move, lives change, right? It's real important to kind of not only keep track of where you've been, as difficult as that is, but if you know that you're moving and you know that you're going somewhere where you're going to be changing healthcare facilities, get your records. any healthcare facility will give you records on a disc, or, will send them to you digitally, not just your images, but all of your records from, the hospital. If you've been admitted, or, your primary care doctor notes and stuff like that, get your records. It's good bookkeeping when you move from one facility to the next. And at a bare minimum, have record of where you've been. So when you go and get your first mammogram, if you move to wherever, I live in Pittsburgh. If I were to move to, Boston, I would say, okay, I had all of my stuff done in Pittsburgh at Allegheny Health Network. And before that, it was at Morgantown, West Virginia, WVU. So have an idea of where you've been. Try to keep track of that. Write it down. Get a notebook.
Absolutely. I just wanted to emphasize those priors again, since we talked about it at the beginning, and also have a chance to talk about it at the end as well. Yeah. There are a few other topics that patients may have questions on. I think that the discussion of preparing, undergoing, and recovering from biopsy is probably its own discussion, but we have about 10 minutes left for other discussion points, and we can perhaps overview some of those points of biopsy and then dive deeper into that topic at a later time. But just kind of the general things that a patient can expect, and what it means if they have to have a biopsy.
So we mentioned it. Yeah, I mentioned it before, and I actually can share my screen now. I was notified that I can share my screen. So how about, as I talk about this, let me see if I can share that. Is it up? Are we sharing?
Yep.
Can we see that? Okay. So this is just kind of the statistics that we were talking about, how, if we're screening 100 women, 90 of them will be normal, 10 will, and this is, generalities, but 10 will be asked to return for a callback. And then of those 10, 6 will be normal, 2 will be asked for a 6-month follow-up, and then 2 will actually be biopsied. So out of 100 women, generally 2% of them will get, out of 100 women that are screened, 2% will need to have a biopsy. And out of that 2%, globally, 33% would actually come back as something that needs to be treated, whether it's cancer or high risk lesion. So I think we're talking here. I can stop sharing this, but this is, I posted the link of this on the Facebook page. So if you're watching via Facebook, the link is on there. You can click, and it still is on the page. This is an ACR website, mammographysaveslabs.org. So yeah, so I'm gonna stop sharing that. Back on to us. We were talking about the people who are getting biopsies, right, and what to expect with biopsies. So it's important to note that if your doctor tells you that you need a biopsy, that's not a cancer diagnosis. So I'm honest with my patients. We're trained to know what's super suspicious and what's not very suspicious. There's varying degrees of suspicion in breast imaging, and so I'm completely honest with my patients, and I tell patients, if I give something a BI-RADS 4A or 4B, I tell them the statistics. In my mind, if it's a 4A, less than 10% chance of this being malignant, but I think it's enough of a chance to where we should stick a needle in it. If it's a 4B, I still say, okay, the odds are still on your side. It's less than 50% chance of this being malignant. Globally, it's 33% chance of it being malignant. And then if it's a 4C or 5, then I'm also honest in that standpoint too. So I like to have my patients who are coming in, who I'm recommending a biopsy, already know before they get, put into the machine to have a stereo biopsy or lay on the ultrasound table to have an ultrasound biopsy, already know kind of, okay, what my doctor was thinking before he recommended this biopsy. But by no means, if other than a BI-RADS 5, you can skirt around the statistics no matter how you phase it, because, just because we're biopsying something, that doesn't mean automatically that it's breast cancer. It's important to recognize that.
Definitely. Ravi, do you have anything to add on that?
Yeah, I'll just reinforce that, biopsy doesn't necessarily mean a cancer diagnosis. We have to understand the limitations of what we see on imaging sometimes. And, sometimes they only take us so far, and to really get the answer or more information, that biopsy is needed. I do also stress to patients that, there's a variety of different techniques, different machines that we use, either ultrasound, MRI, or mammogram guided, and getting a little bit more information about that ahead of time is helpful. The positioning may depend on the equipment, and the vast majority of biopsies are not painful. Some can be have some discomfort, but generally we numb up that area really well for biopsies, and that patients should ask questions about that and not be fearful of that, and pain control and making sure they're comfortable is something that's important to us.
It's important to recognize too, if you're called in to do a biopsy and you know nothing about having a breast biopsy, this is an outpatient procedure. You're not going to get anesthesia. We don't put people under. We don't do general anesthesia. You can drive yourself to the appointment. You can drive yourself home from the appointment. The biopsy itself, usually takes under 10 minutes. The longest part is getting you set up, really. There are some outliers there, and some biopsies can be a little bit more challenging than others, but vast majority of biopsies can be done under 10 minutes.
Absolutely. I think that both of your points kind of tied together the theme we've been discussing throughout this, is that having that conversation with the radiologist is so important, and they will educate you and tell you everything that you need to know about the procedure. And I agree, the biopsy is usually very short, and many patients have the impression that it's like a surgery when they come in, and it's definitely not like a surgery. It's a very
minimally
relatively quick, usually outpatient procedure rather than surgery. And I agree. I usually tell the patients the longest part of the procedure is when they're in the waiting room, and everything else gets kind of better from there as far as timing goes. Jean, did you have something to add?
Yeah, one other thing that I wanted to say, that most of the patients after the biopsy, I would say almost like 99% of the patients who was apprehensive of the biopsy after the biopsy have told me that it was not as bad as what they thought. So just wanted to let all the patients know that, it doesn't sound, it's definitely minimally invasive, and people who have gone through it had said that it is not as bad as what they thought it initially was.
Absolutely, that's so important. We are kind of getting near the end of our time, so I want to give the panelists an opportunity to kind of give their closing thoughts on what patients can do to feel more at ease and comfortable with their mammogram, and then I'll also give a few closing thoughts of my own as well after you guys are finished.
I guess I'll just kind of close by saying that there's a lot of information about coming for your mammogram, questions, as many panelists and we have all said, that it's really not as bad as you hear about or think, and there's people that are available to answer your questions, make it possible, and the goal is to make it so we can detect those cancers early, and the best way to do it is to be informed and ask questions.
Absolutely, Robbie. It's kind of been throughout this whole summer series, in that, patients should not be overwhelmed or be, what do you want to say, timid about asking questions. If you don't know something, if you're scared about something, ask. Have something clarified third, fourth, fifth time. That's what we're here for as breast imagers and physicians. We're here to make you comfortable and do what's right for your care. And we're here to be honest too. So, I sometimes tell my wife that sometimes when we talk, she only wants to hear the only if she agrees with me. If she agrees with me, then she's like, oh, it's so nice being married to a doctor. If she disagrees with me, well, you're just a radiologist. What do you know? So I mean, when we tell you stuff that you don't want to hear, when we give you our opinion that might not sound the nicest, say, yeah, I'm concerned about this. It might be cancer. This really needs to be biopsied. It's this cannot wait another year. We need to do something about it. We're not trying to pick on you. we're out here trying to do what's best for your care, because studies have shown that early detection and early intervention saves lives. And so what our job is as breast imagers, we're on the front line of defending your body against breast cancer. And so the words that we say are not meant to hurt you, or not meant to scare you. They're meant to be honest with you. And if you need clarification, ask. And sometimes some of us have that innate ability to see when something is confusing a patient or whatnot. I try to reiterate things that I think may have been confusing or be a little hazy or whatnot. But at the end of the day, if you're concerned, or if you need clarification, ask. And I'll open it back up to you guys, but just one last thing. You're probably all tired of hearing me. I just want to thank everyone again for this summer. This is an 8-session summer series that was kind of thrown together. I don't want to say last minute, but we were trying to come up with something for COVID, something for us to do as SBI members, and helping patient knowledge and understanding, and patient advocacy and whatnot. And we've had a bunch of different topics, not just patient-based, but also learner-based, trainee-based. This is better than I ever imagined. So I thank you all today. I thank past panelists. I thank past moderators. Hopefully we do this again next year, and it just grows from there. And so everyone who's tuned in, I appreciate it. Hopefully you've learned something.
Yeah, I just wanted to say, I'm just echoing what you guys are saying. If you're a patient, we are here for you. If you have any questions or concerns about, I know we have the whole series about the COVID. We are here. We as breast radiologists, we are the breast doctors that is going to help you find the breast cancer. So we are here for you. And if you have any questions, feel free to contact the breast center. And don't let anything not get you get this mammogram. As we were saying, that there should be nothing that preventing you from getting screening mammogram or diagnostic mammogram. And I also want to thank everybody. Definitely want to thank Dr. Beavers. Like, she has been it was a pleasure working with moderating this session with her. And also Dr. Miller, thanks for organizing this summer series for the SBI Social Media Committee, and all the panelists too. So thank you so much. And such a great fun and exciting.
Everyone has said everything that I wanted to say, but I will just quote Dr.
Your thunder stolen.
I will quote Dr. Byers again and say, there is no shame in the breast imaging center. Ask, and ask again. And if it didn't get answered, ask again. We will try to find a way to get you all the information you need to be comfortable. And as Dr. Miller so well stated, our goal is to save lives. Our goal is for you to be healthy. So any question and all question, we invite and encourage. Regarding the SBI Summer Series, I am incredibly grateful that Matt not only came up with this idea and spearheaded it and organized it and participated in so many sessions, and did so with such grace and great leadership. So I'm so grateful. And I think that we're all just really, really lucky that we've had you to kind of guide us through this great novel series.
It's been a pleasure. Looking forward to next year.
Absolutely. So with that, we'll sign off. Thank you to everyone for joining, and the recording of this will be available on Facebook and YouTube. So we'll see you next time.
See you guys. Thank you.
Bye. Thank you.